So we have got Miss LSM, and she has been planned for stage left midseam bifurcation PCI, and this is after declining CABG or surgery. 55 years old, very young and obese, with a BMI of 35.9 kgs per meter squared. Her risk factors are hypertension. And in May of 2019, she presented with inferior STEMI. She underwent a primary PCI to the proximal right coronary artery, but she had two other lesions, mainly in the left midseam, and she does not want any surgery to be done. So the plan is now for this case to be done live to PCI to the LED and LCX. The hemoglobin is all right. The LDL is still mildly elevated. The echo shows good LV function. There is mild hypokinesia noted in the posterobasal and infroseptal area. And that's the still images that you can see, appreciate the LED, which is fairly long. And from the spider view, it looks as if there's also a significant stenosis in ostial LCX and proximal LCX. That's the close-up view of both images. And that's the right that has been done before. Moving images of the lesion. I think there is some calcification is noted in the proximal LED, but the immediate, subsequent images will clearly show whether this is true and how heavily calcified it is. Euroscore is 0.7. PCI mortality risk is higher than CABG, but once again, this patient doesn't want surgery. So PCI would definitely be an acceptable alternative to this as a treatment modality. Okay, so this is summary, clinical data. Perhaps Goran can lead discussion with regards to how we to strategize and the equipment that we may be able to, what is required for this patient. Goran?
Morning. Do you hear me?
We just hear you.
Hi.
Gavin, is that or Dr. Lee? And Gavin,
Yes.
is that you there?
Yeah. Yeah, this is Ronald Lee, and this is my colleagues and friends, Gavin.
Yep.
And also with the team is Selfie with me, and also Anand and Sweetin as well. So we heard all your discussion, which is very useful and helpful to let us know what to do. So perhaps we can show the first picture, please. Are you seeing the first angiographic picture?
Yeah, now we can see it.
So you see that this is the latest. What we are using now is a 7-French EPU 3.5 guiding catheter. And as you have seen previously, the LED is quite diffusely diseased. At the same time, you can probably also appreciate that the ostial circumflex looks a little bit narrow, which unfortunately this particular ostial circumflex lesion couldn't be well seen at the other angles. Okay? And that's why I heard a lot of things about plaque modification and also imaging as well. So we are going to move on. Okay, can we show the next picture, please? So we have rewired both lesions, as you can see. Now you can see the spider wheel and the RAO caudal wheel. Once again, the ostial circumflex lesion is not very well visualized in this particular field. And also at the same time, at the distal part of the circumflex, there's a lesion. Just now I heard someone, maybe Fahim, saying that we probably have to fix that part before we proceed to deal with the left main. Okay, so and we also did the IFUS as well. Perhaps we can show the IFUS, the circumflex.
Yeah, thank you very much. Now it's really easy to understand anatomy better. We had only still frames, but now we see IVUS. Can you comment on IVUS pullback?
This is a distal part of the IFUS. You can see that it looks pretty good, healthy. The lumen is around 2.0 to me, and then we start to see some plaque at the inferior border. So, and as the pullback carry on, you see that the plaque burden is getting higher. There's some dense fibrous tissue and calcification. And overall here, the vessel gets a bit bigger, but it's still around 2.0, 2.25 kind of size. You see a higher plaque burden here. This is where you see angiographically the distal part of the circumflex.
Yes.
So we are reaching around the middle part of the circumflex, which obviously the vessel get bigger. It's around 3.0 lumen diameter here. It looks all right here.
This is marginal.
This is the proximal circumflex now. You will appreciate the osteocircumflex very soon. But the vessel clearly getting bigger, around 3.5 at here.
But still not
okay.
much plaque.
You can see it pretty soon. Just be a little bit more patient. It's coming. So here is around 3.5.
And more plaque in this.
Measure about 4.
Yes. Now you can start to see it. This is still at the proximal part of the circumflex.
Some calcium as well, but not so.
Yeah. So
3 loop.
here you see the very heavy plaque burden.
Yeah.
The
Yeah.
catheter is being encroached by the plaque.
Exactly. Yeah, very tight in the proximal part.
So we are at the left main already. You go by the lumen, it's approximately 1, 2, 3, approximately 4.0 to 4.5. Go by lumen. And the left main is not really healthy.
It's diffuse disease throughout the left main.
True.
To the
All right.
ostium.
Yes. So, perhaps we can also show the LED pullback as well. Should I?
Yeah, because
All right,
there was also
okay.
discussion on the extent of disease in the LAD.
Right. So this is the LED at the mid-distal segment, which looks pretty healthy as well. Lumen diameter around 2.5. So it still looks a bit healthy here, but we will see the plaque pretty soon. So this is where the proximal LED begins.
Oh, a lot of plaque. MLD2. It's a branch there, diagonal. It's a reasonable sized vessel now. Over 3.5. Septal. Lots of heavy
So
plaque
this is
there,
ostium of the
hypocalcific,
LED.
Yeah.
Yeah. Very
So
heavy plaque burden.
large plaque burden at the ostium.
There's a lot of possible remodeling here.
Yes, precisely.
That's a circle.
And we are coming to the
This left main. Left main's massive.
Yes.
At least more than 5.
Right. So, okay. In view of the time issue, we actually have fixed the distal circumflex. We put in a stent. Can we show the angiographic picture, please, after this one? So we pre-dilated with a 220 balloon. Next one. Next. Okay.
So these are still predilatations.
That's true. Next.
And then repeat IVUS.
Next. Okay, next. Now this is stent.
Now
so
it's
this is
stent.
a yes.
So which stent you selected?
This is a Medtronic Onyx 10, size 2.5 times 26.
Yeah. And it's
So,
actually selected based on IVUS evaluation.
Yes, that's correct.
So we noticed that during OCT and IVUS is that when OCT is automatically measured, and then you're scanning landing zone. And for all the old guys, we used to just read the IVUS really quickly, but now we have to go back and measure and actually assess properly, do the measurements, check the landing zones, measure the length. It's the quantification that's also the power of the imaging.
Yeah.
I think the IVUS sort of emphasizes the fact that it's so important to IVUS the circ on its own and not just look at the circ ostium from the left main pullback, because you see that the circ ostium is heavily laden with plaque.
Exactly.
And that changes your strategy. Obviously, you now really have to do a two-stent strategy.
So, Dr. Lee, we saw nice result after distal circ stenting. Please share now what is your selected strategy.
Okay, so Gavin and I decided to use a cool-up standing strategy because we use that because apparently, at least angiographically, the circumflex LAD, the size is not much different from the left main. And we feel comfortable with it. So where this is what we are now, and we are going to do a real-life procedure now. So the first thing I heard about is the plaque modification. So we are going to use a cutting balloon to treat the osteocircumflex lesion. The intention is to do the cracking and to minimize the plaque shift to the LAD.
So how are you sizing your cutting balloon to the IVUS?
I myself try to be a little bit more conservative, so I use a 2.5 cutting balloon first, knowing that sometimes the profile may not be the best.
Is it a flex tome or a Wolverine, which is a lower profile version?
Yeah, I wish I could use the Wolverine, but at this moment, we only have the flex tome at our cath lab. So probably early next year.
It only sounds good if Hugh Jackman's in town. He's a movie star, Australian. But it's quite low profile. Yeah, not much around Wolverine.
Ronald, this is Fahim. Just out of interest, is Coolot your strategy of choice? I mean, there's randomized data that says that the DK crush is better than Coolot for long term.
That's the European guidelines.
Yeah. So why do you choose? Can you tell us why you're choosing Coolot instead of DK crush?
Indeed, for myself, my preferred strategy is professional stenting because apparently in terms of data, is the best. But in this particular case, we choose it because of the size of the side branch and the main vessel similar, balloon up. Okay. And it's something we are comfortable with, and we know that we are going to present various strategy in this course of different kind of standing strategy. So someone else will present the DK crush shortly. Okay,
Yeah, I think there are different options. Most of them are probably adequately performed equal regarding the long-term clinical outcome. We don't have comparison directly. So I fully support operator, and he will select strategy that he's most familiar with. And I really think we should proceed with Coolot.
Okay, so this is a cutting balloon 2.5, went up to 12 atmosphere.
I took part in the randomized clinical study between TK Crush and Coolot, and the study clearly showed that the TK Crush is superior. That's number one. And number two, if you look at the branching here of the circ, it is practically perpendicular. So I think TAP would be a better choice rather than Coolot if you don't want to use TK Crush.
Yeah, Teguh, I think it's again operator selection, and we really need to support him. I know there are different options and there are different personal preferences, but here we are to see performance from the Singapore, and Dr. Lee is one of the most experienced interventionists, and I fully trust in his selection.
Agree.
Thank you very much. I equally respect all the different comments here.
Hello, I'm Liu from Malaysia. Just like to ask, if you choose to do culot, which vessel you will stand first?
I would like to set the circumflex first because this is the angulated branch. Hopefully, the stand will open up the truss for me to wire the LED easier.
So you go for the more angulated, the more difficult one first?
Yeah, sort of correct.
Would
So
you-
as you can
would you
see
put-
live that
Would you put one balloon for protection for LED?
no, that's not the plan for this patient. Okay, so pull back. So we are putting the eye first down to the distal circumflex.
You want
eye
to
first
evaluate stent expansion in distal circ, but also predilatation of the ostium.
Yeah, okay, a little bit more distal. More distal. Okay.
Yep.
Distal more. Okay.
Looks like very good, well-deployed stent there.
Yeah.
So we are doing the pullback here. This is the distal part of the circumflex. You can see the stent truss.
How high did you go with post-dilatation just now? Pressure, yeah.
For this particular stent, we took our 275 high pressure balloon who went up to 20 atmosphere.
Yep. So you can see the high pressure balloon, and at high pressure, non-compliant balloon did its work. The stent is really well expanded and well opposed.
Yeah.
That's
Yeah,
a
very
good,
symmetric.
A very good result on imaging. There's a little bit of plaque just proximal to it. That was a little bit smaller here.
I think that was the part where the eccentric plaque was. But again, he's gone to very high pressures. Whilst we wait for the images to come on, so the question on REACT is this. Would FFR for LCX be useful, Dr. Zhu? Would you think that you would use an FFR in this case, or you say just IVUS is adequate enough?
In this case, I feel FFR maybe help because when we just read through the IVUS, we feel like this plaque is not really very calcified, and the MLA is something around 4. So I mean, maybe for me, I will just do the FFR to see whether the functional significant or not, whether to treat. And also the ostium is very focal lesion, very, very focal. I mean, it's very tight, but it's very focal.
I think, Rossley, the issue is for FFR, it's not to the decision to whether it goes to stent is driven more by the anatomy. Are you going to have a carina shift and squish the circ after you stent across? And I think when you see that much plaque at the ostial circ, I think realistically you kind of have to adopt a two-stent strategy in that situation, regardless of what the FFR is.
Yeah, for him, I absolutely agree with you.
Probably you have to frame your question. What the FFR, when did you do the FFR?
Yeah.
So if you're deciding beforehand versus if you've stented the left main and you're checking the ostium, the circumflex, or remember there's a crosstalk between lesions in the LAD, which is very significant, and also that will affect the flow if you correct one side versus the other, which is, so if it's positive, it's fine, but if it's negative, it could still be positive if you fix the other lesion. So,
Agreed.
yeah.
Yeah.
So you have to repeat anyway after stent.
Correct, yeah, so it gets more in the algorithm, it's more complicated.
Yeah. But if you select upfront culotte and if you select inverted culotte, then you are stenting circumflex first because it's
That's right.
very angulated vessel, and we all commented on
Yeah.
angulation. So
Yeah.
from that perspective, maybe FFR will not play a role.
Yep.
But in general, I fully agree with you that you can also use it at the baseline.
The other thing is what kind of culotte? Is it a mini culotte, or do you want to put the first stent directly flush on the ostium of the left main? Because there's disease there. We'll need to cover it with one of the stents.
So, Ronald, basing on
Yes.
what your IVUS and what is it that you have made the decision on? Culotte, like someone when Sydney was saying, a mini culotte or a proper culotte?
Yeah, big culotte.
All right.
Overlap.
I'd love to hear comment, but at this moment, after looking at IFRS, our plan is to do a full culotte because the left main is not really healthy and a lot of plaque burden there. But I'm open to different opinion.
So you need to make sure you know the stent expansion for your IVUS sizing because you need to get it big. 2 layers of stent big in the ostium.
But even if you try to minimize, you can minimize with the second stent. You don't need to minimize now. So the amount of overlap can be decided also for the second
Exactly.
stent.
As long as you cover the ostium.
Yeah.
Okay, Cindy. So, okay, Cindy. So we are at the stage that we have
Oop, freeze.
did the IFAS confirming that the distal circumflex stent is reasonably expanded, and so we have reached a stage that we are going to implant the first stent to the circumflex and left main.
So what is the selection of stent? Which diameter and length? We know the type of the stent.
We have chosen a 3.5 times 26 millimeters.
Okay.
Yeah, please.
So he will stand from the ostium into
Yep. Can that
to
be
fully cover the circle.
a lot of the big vessel stents would take to 5 at least, I think. Yeah. But the bigger ones like 4.0 would take to 5.7 in the Boston and other companies. Although the Onyx comes with a 5, actually with dedicated 5.
Yeah, I think 3.5 you can dilate up to 5.5.
Yeah,
And
so comfortably.
then, yeah, comfortably.
In fact, there's going to be somewhat a little bit of a 2-layer part of it, so there's slightly more drug if you're concerned about less drug from when you're ballooning small stents to a large size.
So, Goran, what's your strategy? After you deploy the stent left main into the circ, would you pot first?
Yeah, always.
Always
I mean, culotte, if we do it contemporary culotte, it means stenting one vessel, pot. Opening of the struts, stenting second vessel, again pot, then kiss and final pot. So this is the sequence that we try to recommend.
So if you're all a bit confused about that, hopefully this case will show how contemporary culotte is going to be done.
I'm absolutely convinced of that.
Stand up.
Looks nice.
Yeah, looks very nice. Big stents,
Yeah.
nice coverage. People frequently speak about image guiding, and now you can clearly see the benefit.
Yeah.
You understand the sizing, you understand the amount of plaque, distribution of plaque. Really makes life much easier.
Balloon down. See that.
How high do you go, Ronald?
I went to 10 first.
10 first, yes.
Try to be more conservative. Okay, take out the balloon. Yeah. We will put an IFAS later on. If needed, we can always post dilate.
So you just went to 10, you didn't pull back a bit and go very high pressure?
We try to get another balloon to do a high pressure inflation. A pot. Okay.
All right. But I think that the pot is also very important because you don't want to be pulling out the wire and going out from the stent struts. So by making sure that the left main is opposed to the wall, then you reduce that risk. Otherwise, you may deform the stent.
So in the culotte, you have to dilate the cell to the size of the vessel. So I guess you have to also understand that that can be done without rupturing or distorting the stent too much.
Yeah. Yeah, but with contemporary open cell design, I don't think it becomes issue. We remember publications from John Ormiston with Cypher. Of course, if you have limited closed cell design, it's issue. Here, you don't really have that problem.
What do you think of the ultra mini culotte, just like one cell that you stretch to put the second stent in?
You know, I remember flower petal and technique recommended by Japanese group, but you need to be so skilled to catch just one strut and then open one strut. I don't see a really huge difference if you try to minimize, but minimize enough to fully cover the opposite wall.
It's
and
easy to
it.
do, easy to
and
do.
it's easier to do.
Once again, the two-stent strategy, as long as you're comfortable and can get good result, You just keep doing what you're doing. I think.
No, absolutely. If you do culotte every day, when you need two-stand strategy, T or culotte, you should not shift suddenly to decay crush. But I also fully respect Dr. Santoso, who participated in all decay crush studies. I know that he can close his eyes and do all the steps of decay crush without even thinking what is the next step. So we should keep working on what we believe is for us the best two-stand technique.
So Ronald, is that a balloon to
Yes.
pot or?
This is, yes, but this is still a relatively small balloon. My plan is to post dilate a bit first, and then we maybe get imaging to decipher the size of the balloon.
So it's actually the area where the tightest plaque was located.
But once again, I think I mean, we're talking about mini culotte and so on. But I believe generally for a lot of us here, if you want to do a culotte, you should bring it back substantially into the left main, and it makes life easier because then you are sure that when you wire, it's quite more likely that you're going to be within the stand struts. Otherwise, if it's too short, you may actually end up like in sense of kissing,
Yeah,
kissing
fully
stand.
agree,
So I
fully
think pull back to be safe. Just pull back, and you'll be all right.
Yeah. But this is really nice demonstration step by step. Nominal pressure to deploy, then optimize distally, then use spot to optimize proximally, really trying to achieve best result with each separate stand, and then final kissing.
And
Okay,
I think this is also a good technique to use a short balloon and try to place it almost perpendicular to the branching point in order to be able to make the struts in the carina well opposed to the vessel wall. So also when we are doing kissing balloon dilatation, use the small balloon and try to make the both stands, especially the short stand in the side branch, almost perpendicular. So the kissing part of the balloon should be very minimal.
So more like a hug.
Yeah.
Otherwise, you'll get kite wire bias and balloon bias, and then you will leave the carina left unsteadied.
Ronald, you're doing IVERS again. What do you hope to achieve by doing this IVERS at this point in time?
I want to see whether the stand is adequately expanded, and also whether we need to add another bigger balloon for the port at the left main.
Looking very
So
good.
this is the circumflex. It looks reasonably okay.
3 across, one was 3. At least MSA about 7 there.
So we are coming to the osteo circumflex very soon.
Gordon, let me just ask you this. If it's my practice that I deploy, let's say 10, 12 I'm concerned about, and I pull back slightly and go high pressure before I port left main, would that be a wrong procedure, a wrong way of doing it?
No. Of course, I agree. I will do always the same.
Yeah.
Pull it back few millimeters just to get inside the stand, deploy very high pressure. And also with decay crush, I like the improvement. They recently started optimally dilating ostial part. If I'm not wrong, Dr. Santoso, please correct me. But by optimal deployment at the level of the ostium, recrossing is much easier, and you have much better expansion before crushing. So I think with any of the technique, the most critical part is very ostial one, and high pressure dilatation in that area is extremely important.
So Ronald,
Yes.
from the findings, can you just summarize the findings and what you're going to do after this?
All right, so the stand expansion based on IFAS seems reasonable to me, including the plug at the left main. The only thing I'm a little bit unhappy is the stand expansion at the ostium of the circumflex, where most of the plug burden is located. Seems to be not perfect, but I think I'll leave it to the final kissing balloon to deal with it. So we are moving to the most challenging part for culotte stenting, which is the wire exchange. This is what we're going to do now.
So you just took a 4.0 just now to pot the left mean and ostial of the circ, right?
That's correct. I went up to 16 atmosphere.
So crossing distal cell is really the most important step of culotte. If you cross proximally, then there is a metal that you always shift from one side carina to the other. And sometimes you see hazy appearance, which is actually caused by a little bit too proximal recrossing. There is a question from the audience, should we remove jailed wire, recross side branch before post-dilating main vessel? If somebody wants to comment on that one.
I would usually leave it in till the other wire is swapped around. So because it keeps you access to there, and you can always convert it in an emergency situation to a reverse crush.
Exactly.
But you want to make sure, leave it there, you marks that wire, and until you secure access to it through the stent to that branch.
Yeah, fully agree with you. So first pot, post-dilatation, then recrossing, and then removing the wire.
But you're concerned about jail wire, it is not something you should be afraid of because left mean stem is large, so it will not, the wire in the circumflex will not be jailed, or the LED will not be jailed.
But in some situations, I get very nervous in complicated ones, and I'll leave both wires and get a new one. There is a slight risk you can go in and out stent strut to go through that, but sometimes, in a sense, you don't lose any of your access site. You have access to the stented circumflex, you have a trap wire, you're just securing access to the LED. That's okay if you can afford an extra wire.
I think the trap wire also gives you a little bit of anchoring to when you have to jam your balloon through, especially in the DK crush situation, so it's not unreasonable to leave the wire.
Yeah, I agree. I think the trap wire has some pros and cons, but there are situations we have to be very careful with trapping. The left main or the LED is very calcified.
Yeah,
and sometimes you do get trap wire. And of course, the worst case scenario is you just take a third wire.
Yeah, thank you, Sydney and Fahim, for explaining for us while we are doing the procedure. Yeah, this is the intention for lifting the trap wire just now. But now we have taken it out, we are putting it to the circumflex.
So flip-flopping the wire. So this is a question that I specifically want to direct to Goran.
Yes.
If the circ ostium is well prepared with minimal dissection recoil, would you consider DCB? And then step to LED.
Yeah, I know that you keep asking me that question at every meeting that we are together, and I have to defend myself, and I say, as long as I don't see publication documented the benefit of DEB for the ostium of the side branch, I'll keep saying no. But it's very logical, and I really strongly encourage all of you who have data on DEB use for the ostium of the side branch. Please send your data to Dr. Rossley. I want him to publish once, and then we can continue using his technique.
One Azman, please take note. Okay, we'll leave the tips and tricks subsequently, the other question.
You just check her arm. She's a bit uncomfortable.
So, Ronald, what balloon are you thinking of dilating the stent struts?
Okay, right now we are using the a 2.25 times 20 balloon to prepare the proximal mid LED and maybe use it to dilate the stent struts as well. And as you were talking, we have taken a picture after the stent placement to the left main circumflex. You could probably appreciate that there's quite an amount of plug shift to the osteo LED, and it looks not as healthy as it was earlier. So we are now putting a balloon to the LED through the stent struts and to prepare the lesion.
Yeah, the other wire, yeah. But you can also use this wire to anchor. In case you have difficulty, you can inflate balloon in the circle.
That's right, yeah. Very safe, you've got stents already there, and that's a good technique.
If necessary, we hope that after adequate pot, if you actually do proper pot, and if you position marker really very distally, in front of Karina, you open access towards the LED, so it's straight.
Yeah.
I don't expect problems.
So it's important to know after kissing, though, not to do too distal apart because you destroy the whole benefit of the kissing.
Yeah, while we are waiting for procedure and we let operators calmly work, the issue of final pot after everything, I think it's still so open, and with increased use of OCT to evaluate the impact of kissing and final pot, what we learn is that with kissing we create some elliptical deformation, but with second pot, it's so frequently that we go too distally and we actually spoil the result. I think, I'm not so sure if it's really mandatory to do final pot after kiss, and even if you do it for just osteo, to make sure that you open correct longitudinal deformation if there is any. But I will not dare to go with balloon deeper inside.
My understanding, Goran, is that the final part is it has to be proximal to the bifurcation.
Yes.
Very proximal.
Yes, exactly.
But you know, issue is that when you start inflating, as soon as you reach resistance axially, balloon extends longitudinally, and you unintentionally crush what is protruding.
Do you think that happens when you use very small balloons, or is that?
Whatever balloon you use, if you use OCT after that, you get disappointed. You always have carina shift and you compromise the ostium of the circ. So it happens so frequently that people who use OCT like Niels Holm or Nicolas Amabile, who is here, they are so disappointed with performance of final pot. I'm not so sure we will keep it as recommendation as long as we learn how to do it very proximal.
And that's not just for culotte, right? That's
No,
also double
no,
kissing.
that's
Any
for
anything.
yeah.
Okay.
I'm not so optimistic as it was initially with pot side pot. First, when you do kissing, you put carina in the center. So you not only expand proximally, you position carina in the center. But with final pot, you shift carina back in one or the other direction, which depends which wire you are using.
When you do your kissing, do you actively try to keep the proximal balloon markers in the polygon, or do you actually not care too much?
I do care, and I try to use short non-compliant balloon for kissing. There is no need really to go to very high pressure if you size according to distal reference, but it's very important not to go too proximal, because in the polygon of confluence, you already have an elliptical shape. So it's already elliptical. If you do kissing in that area, you don't need final pot.
Okay, Ronald, one stand or two stands?
Two stands. The reason is that when we did the IVUS earlier, there's quite a significant mismatch in the size between the mid proximal LED and also the left main. So our plan is to put in a 2.75 to the proximal mid LED, and then another one from prox LED to the left main.
Yep. Okay.
Would you protect the diagonal?
That's not our plan. I will try to keep it simple at this moment. As the patients are getting restless, the BP is getting a little bit lower. Okay. So can I?
Okay. So we'll let you work for a while. 2.75, maybe 26 or 24 or 22.
26. Can I have a 2.75, 26?
Dr. Huang, can I just ask you, Dr. Huang, if I can just ask you, one of the questions is, there are two parts to it. What is the best wire that you'll use to recross through the sensor?
I think every work wire, soft wire is okay. This is not typical. It's easy to close the stand track and use the work wire. Soft wire is okay. But for this lesion, maybe I will choose shorter stand for the circumflex. The second stand, I mean, the proximal. I don't want to choose so long stand, and then a little proximal. Mini culotte. Almost
more mini.
Shorter to the left man, and then it's easy to use another stand to close the LED to left man. It's okay. That's longer to left man side.
Or a short culotte in the circ, left into circ, and longer for
Circle,
LED.
yeah, yes.
I think that Goran already mentioned to facilitate wiring of the branch, then the pot, the dilatation of the coronal cells really help that. And so that's one thing you should do if you're having a lot of trouble. You haven't optimized it. And if you've got imaging already, you can check that too if you're not sure. And that would certainly help wiring of almost any wire. Workhorse should cross reasonably well, particularly in this large vessels.
Yeah. If I can share my personal preference, if I have difficulty, Asahi, Renato, or Pro Water, depends in which part of the world we work, is my favorite one to recross. I really feel steering with that wire, at least in my fingers, is the best one that I can have. So I shift from run through to Renato, and then I switch to hydrophilic if I don't succeed. So this is the sequence.
Yeah. But with regards to the stunting technique for culotte, I think for the general audience, we just want to make sure that they do it safe. Therefore, the amount of distance or length of the stent must be fairly long, because at least you know that you will be not you cover the lesion and osteum, and at the same time it's easier to cross and do a complete jump.
So I have used mostly my workhorse wire, Sion Blue, sometimes Sion Black. They work very well. As long as you post-dilate the cells and pot. Occasionally, rarely use a dual lumen catheter.
Yeah, but only in case of really severe difficulties.
Correct.
So now he's still pre-dilating, preparing for proximal stent. And again, we should see now the result after distal stent, and now we focus and concentrate on left main.
Yep. So how high did you deploy the stent just now, Ronald?
I deployed it at 12 atmosphere.
12. So you need quite a long stent to cover from the ostium left main across to the prox LED.
But
that's true.
I think it's operator preference. I don't advocate anything as a general rule.
No.
If you stand from the ostium with the first stent, it's really not mandatory to go again.
Sure.
So it's your selection and your choice. I like what Dr. Osley just said, to be a little bit longer to make space for nice pot proximally or nice kiss, but I don't think it's mandatory to always go from the
I think the imaging, as you said, helped us about where you land a stent. Sometimes you don't have to stent the ostium.
3, 5, 2, 2.
Okay, so what's your next stent going to be, left main to LED?
So we have pre-dilated stent struts.
Yep.
So this is angio after stenting?
Yes. Angio after the pre-dilated LED and left wing as well.
Yeah, this still looks very good. No dissection.
Yep.
So, well, if I want to get a 3522 to the LAD left main, does anyone have any disagreement?
No. All right. So whilst we're waiting for you to take up the stand, so one of the questions is the concern will always be side branch, especially the ostial complex, restenosis in long term. And we find that. So the question is, what are the tips and tricks that you would advocate to minimize restenosis of circ?
Not to stent the ostium of the circ.
In a two-stent technique.
No, the two-stents technique. It's a qualified question.
Okay.
Drug-eluting balloon user.
I try to sell my personal preference, but you don't allow me. So, like it was done, imaging guiding post-dilatation and optimal result, but I don't think, this is the area of a hinge. So LAD in every heart movement goes this direction, circ goes the opposite direction. If you have a lot of metal in that area, of course it's continuous trauma in that segment. And when people say we should have a lower threshold for stenting the ostium of the circ, I say it's exactly the opposite. You should actually try to avoid stenting the ostium of the circ after starting provisional as long as it's possible. And of course, if the result is not good, if you have tight lesion or compromised flow, you have to stent and then optimize result. Optimize result by performing imaging guided optimal post dilatation. It's maximum that you can do. And of course, you work with new generation stents with thin struts, trying to minimize on that side. This is my personal preference, but as I said, if I can select provisional, I think it's the best to reduce restenosis, especially in lesions which are short. If we speak about DK Crash 5, we need to be aware that mean lesion length in DK Crash 5 was 16 millimeters. So it's not something that can be treated with provisional. I mean, for 20 years, we know 16 millimeter needs stenting. And I have no doubt that provisional is not good for that kind of complex lesion.
And DK Crash 5 also, the angiogram drove revascularization, which is an endpoint. And so...
No, but I speak, this was really extremely complex lesion subset. And of course, for me, it's expected the results are like it is. I just don't like to generalize that to every left main. And this is something that we need to keep discussing, and we need to wait for EBC main. EBC main, I hope, will finish enrollment soon. So we'll see. If we have confirmatory data also in Europe, maybe two-stent strategy is really better.
So if you have to do two-stent strategy, you should do it really well and get maximum apposition to try to reduce restenosis.
But if you properly do it, I don't think that good culotte with image guidance, with all post-dilatations, is inferior to DK Crash. We just learned with time how to properly do one, second, and the third technique. And I think nowadays, performing two-stent technique is not the same as 5 or 6 years ago. We didn't have this knowledge. And now we really acquired huge amount of experience and knowledge, and we try to share it. This is the purpose of this kind of sessions and symposia.
I think the key, the key is that, when you dilate the circ ostium, you have to dilate it adequately before you stent it. Then once you put in the stent, dilate it again with high pressure. And then when you do your final kiss, again, high pressure 3-step kissing is likely to minimize the likelihood of circ restenosis. So it's a lot of work, but it pays off in the end.
I guess the flow changes that occur if you have any sort of strut malposition around the carina will have low shear forces and encourage plaque that doesn't usually form with the flow divider, but will form, and much more encourage restenosis in that spot. And that's the weakness of two-stent strategy if you do it particularly badly.
Okay. I would be very curious to see the IVUS findings, whether the result is satisfies the formula 5, 6, 7, 8 of Dr. Park, 5 in the circ, 6 in the LED, and 7 in the polygon of confluence, and then also 8 in the left main. If we satisfy that criteria, I would foresee that the long-term result would be very good with the...
Dr. Lee, maybe repeating pot at this point will help you recrossing as well.
Probably should aim for as big as possible.
Ronald, so what pressure did you go just now?
We went to 12 atmosphere for the stand for 3.5, 22. How you call it?
But the question is jailing the circ wire between two layers of stent a concern? I would say that it should not be a concern because, once again, the left main stem is large, so you shouldn't be too overly concerned.
Right. Okay, so fortunately, we have completed all the wire exchange already. So we are moving towards the near the final stage of kissing balloon angioplasty.
Okay. Well, I think we still have got time because we've got 5 minutes with you. So for you to kiss, high pressure kiss, and probably
So I think we talk about how to prevent restenosis in the osteocirc. So I think this step is also as important. When we recross the circumflex, we try to get as close to the carina. Is that right?
Exactly. Yeah, and then 2-step final kiss, actually high pressure individual inflations, and then moderate pressure kiss.
So they want to know exactly, is it proximal or distal?
I will be happy to know, but considering that angiographically it really looks distal, I would not repeat imaging at this point, but after optimization to check the rule of 5.
No, I'm talking about wiring. You're going
Yeah.
for proximal or distal?
No,
spread
always
filter?
distal, except for
Always
decay crash, always
always
distal.
distal, right.
So every technique except for decay crash is
The
distal.
middle. Yes.
And in decay crash, we need to learn from masters how to cross centrally, not too proximal. Teguh, am I right? If you cross too proximally, you create metallic neocarina.
And for Santoso is right too, is that you get big areas, as big as possible. They're the minimum standards in the Jang paper. And I think in Excel, actually, the left main OCT was much bigger. It's like 10 millimeters. So they've more than satisfied the 8 or 9.
I mean, 5, 6, 7, 8 is actually something that will help you to guide. But you know, the bigger it is, of course, the better. And but I find that in beginning years ago when I first do this 2% strategy, you know, I love doing it, and until I knew that it was not the right way to do. But if you have to do a 2% strategy, it's very important, as has mentioned before. Make sure the size, make sure you go very high pressure. And you know, that extra step of going very high pressure helps to dilate a bit, and you know, and reduce that risk of restenosis. So I think that's an important step. Very high pressure.
So which balloon is that, Dr. Lee?
This is a 3.515
Okay.
to the circumflex first, and we are going to insert another 3.515 to the LAD as well.
Okay, so it's actually stent size.
True. I heard a comment just now that we should do a sequential high pressure dilatation, and then followed by a moderate pressure kissing balloon angioplasty. Do I get it correctly?
Yeah, I completely agree. We normally do a sequential balloon dilatation with maximal pressure, and then kissing balloon dilatation with nominal pressure, and then followed by pod.
And then followed or not by pod.
Followed by pod.
Yes, of course. Did you dilate the Circ stent with a 4.0 before?
Yes.
Yeah.
He did.
Yes.
May I ask a question? I know operator preference, 3.5 stent. I wonder whether anyone would go for a 4.0 stent and go a little bit lower pressure, and pull it back and go high pressure.
Yes.
But as long as you use IVUS imaging, I think you follow what you measure.
Exactly.
I think if you
comfort is in
dilate
that.
it adequately, you should be all right.
You should feel safe once you've measured that you're not crazy about the size.
Yeah, as a strategy, if you go low pressure, that's not, I don't think, dangerous. But just if you use imaging, then you base measurements on imaging.
Yeah.
And I think this is really very nice demonstration.
Yeah.
He did so many times repeated imaging to evaluate every step. And I really respect that kind of persistence. And I really congratulate operators on being so persistent to guide every decision based on imaging.
So Ronald, just
Yes.
you know, keep us up to date with what you're doing right now.
We are in the process of dilating the circumflex stent.
With a non-compliant balloon?
Yeah,
Use a
3.5.
non-compliant balloon.
Accuforce.
3.5. Okay.
3.5, is that?
Yeah,
18.
like the stent. Both are 3.5.
Okay. Balloon down.
The thing that has changed is that my usage of very large balloons in left mains has significantly increased with imaging. So 5.0, sometimes 6.0, 5.5 NC balloons.
Yeah, Sidney, thank you very much for that comment. I frequently discuss with colleagues, and then I ask them, and they say, I did IVUS. But what kind of change in strategy use of IVUS made? Have you used bigger balloon? Did you achieve 1 square millimeter larger stent area? I mean, just I did IVUS does not work on intention to treat. So you really need to do something with measurements that you do.
So right now we are going to the LAD left main.
I think I will mention that for many labs, IVUS is sometimes difficult. They don't have it. So I think it's just some general rules to keep in mind. You know, the left main is never 3 millimeters in any human being. So, you know, you have to think in terms of 4.0 and above for the left main. So keep those numbers. The proximal or ostial LAD is never 2.5 in a human being. It's usually 3.5 and above. So if you're not going to use IVUS, then have some general numbers in your mind to know what sizes you're going to expand to.
But I think it's very important to have at least access to imaging. in case of complication or problem, even if you don't start with IVUS.
Oh, I agree.
You
But,
can evaluate.
but some labs just
Yeah,
don't
of
have
course.
it. So
No, of course.
yeah.
I just to be on the safe side. Procedure is done really very conservatively on the safe side, and to be on the same side, I say it's nice to have access if you don't use it routinely to be able to use it if needed.
And we've definitely seen some small Asian ladies with very large left mains, 560. So, you can't go on body habitus about the size of the left main.
Okay,
It's
Ronald.
the size of the heart that matters.
Two questions. Firstly, what was the pressure in the LED and circumflex? And secondly, is what is kissing pressure now?
All right, sequentially, when we did the post-dilatation, we went up to 16 to 18 atmosphere.
Right.
And just now at this kissing balloon, we went to 8 atmosphere simultaneously.
Okay.
Okay, take out the balloon.
So,
we are going to
yeah. After
take
this,
out the balloon.
are you going to do a pot? Because you have not done a pot in the beginning?
I'm thinking of taking out the eye first to take a look.
All right, okay. We
But
are going
I
to give
will-
you an extra about 3 minutes
Yeah.
before we end.
I will definitely do pot, at least for the ostium. You work with jailed wires, you work with 7 French guiding. I think final inflation protruding into aorta is really strongly recommended, and then we can do IVUS if we have time.
Yeah.
Good, okay, we can do that.
It's pragmatic. I like that.
Do you have any balloon
think 5
size you
balloon.
prefer for the pot?
I would do 5 balloon.
I think 4.5 to 5, something like that.
But you didn't put the stent until the ostium left main, do you?
Not exactly.
Not exactly.
Oh, okay.
So, Goran, would you be respecting the stent that you should?
Yeah, I had the impression that stent from the circ went up to the ostium. That's why I said you do ostial post-dilatation, but if you are sure that you didn't cover the ostium, then forget
I wouldn't get. I'll do 4-5 then.
4-5, yeah, not to be on the safe side.
Is the wire okay?
Okay. I think we'll have to answer these 2 questions, and I'll just give it to you to answer. What is your best strategy for ostial LED? What is best strategy for circumflex, other than drug-coated balloon?
Yeah. Okay, I don't like drug-coated balloon for ostial circ, I have to say. I mean, I like the idea, show me data. Best strategy for ostial LAD for me is crossover stenting. It's predictable, safe, I know how to do it. Everybody in this room who is doing bifurcations, I think it's much safer and more predictable to stent crossover, do pot, and then evaluate result. For ostial circ, inverted provisional is something that I will advocate, which is stenting from the left main into the circ if possible, but I really fully respect if you have a really short lesion at the ostium of the circ, functional evaluation to document significance, and then DEB is good option. Just for the sake of our continuous discussion, I always say no DEB, but personally I think it's good option.
I'd like to qualify your osteo-LAD comment, and the reason for stent over is because on all the imaging studies, the plaque does not stop at the osteom-LAD. Almost all the time extends directly in the left main. So if you cover the plaque, you get a better result, and it's also easier, more predictable procedure.
Yeah.
I think for ostial circ, Rossley, we've anecdotally done cases where we've used a cutting balloon and DCB and had very good results, even on long-term angiographic follow-up. So it is an option. It doesn't always work, but it certainly is an option to keep in mind.
But it's an often,
But it's anecdotal. I mean,
often asked question because it's a dilemma. You are doing a circ, which is not prognostically important vessel, for example. Now you may actually end up by even treating the left main and LED. So that's always a
That's why I said you have to be sure that it needs to be treated. FFR is, I think, good option, and I fully agree with you that you should evaluate. But then if you have to do it, then you have to do it predictable and safe. For me, crossover again, inverted provisional is predictable, safe. You know how to do it. You saw ostial circ stenting in the first phase of the procedure. I think if you have to stent it, if size of the circ allows, then provisional is better.
I want to ask the panel's opinion regarding Dr. Murasasto's suggestion. If we have a bifurcation where the angle of separation is perpendicular or close to perpendicular. If you want to do a kissing balloon dilation, we should avoid putting the proximal part of the balloon too much into the main vessel, because sometimes this proximal part may switch, and then we will cause overdilatation in the main vessel proximal to the bifurcation side. So if we have this kind of situation where the angle is close to perpendicular, the protrusion of the balloon in the left main should be minimal.
This is where is it?
No, I absolutely agree, and we saw it also on bench testing, and you cannot prevent twisting of balloons. As soon as you start inflating both balloons, you have partial twisting, and the amount of twisting is unpredictable. So I fully agree to minimize proximal overlap.
And that's what the investigators are seeing in the October study.
Yeah.
Okay, Ronald. So
Yes.
he did a pot in the ostral or proximal, so he avoided going back again into the
Yes.
carina, which is nicely done there. When at 10 atmospheres, I suppose it's not disease, and that was a 4.5. Now, we are going to probably have about 2 minutes.
Okay.
Perhaps if you can just take one final picture and IVUS of one of the vessel, at least we can see
Okay, we will
the
do that.
results.
Yeah, we are now putting in the IFUS catheter into the LAD left main, and we will do a pullback live to show you what we have achieved.
Okay.
Can we see a picture too, or?
Yep. An angiogram, perhaps?
Sure, maybe you do an angiogram now.
Very nice.
All right.
Very nice, very nice.
Very nice.
You know, when you see this beautiful image, it's difficult to say you should stick to provisional. With provisional, we'll never look this nice.
Of course, two stand is better than.
But you need to persist.
It's been a very systematic and very well done. You know, stepwise imaging, sizing.
对对对，即刻。
Very nicely done, Ronald.
Okay. Well, thank you. So we are doing the IFUS now. The pullback, we are starting from the proximal part of the LAD.
One interesting question. With provisional left main stem stenting, do you open the stent struts of the circumflex if it's just a single stent strategy? Provisional?
I don't.
Yep.
It's controversial. I tend not to.
Yep.
It's controversial, I always do.
Yeah.
The Japanese things that always creates flow disturbance they don't like.
Sydney, I worked 3 years with Antonio Colombo. It's very difficult to change mind after 3 years with him. So he doesn't like metal in front of the circ.
I understand.
So it's easy to remove it. It's part of the time that is 5 more minutes.
Yeah.
And you really impaired flow, as you said.
So, yeah.
You really remove
create
the
pla-
metal
yeah,
and
yeah.
you create better shear stress profile.
So you
So you are
routinely
seeing
open
the
up the stent
stent at the
struts?
left
Yeah,
main.
unfortunately, I don't have data to convince you, but I think from the perspective of computational flow dynamics, and I'm sure that one day we will guide procedure by shear stress,
All right.
not by OCT.
IFUS
percentage
Shear
of
stress
area.
profile will be better.
Ronald, before I go back to ask you, but what
Yes.
size balloon would you choose if you open the stent struts of the circ? A smaller balloon?
Smaller balloon, yeah, you don't need to insist.
So remember, don't go too high because otherwise you're
Yes.
going to injure the circumflex. Just
That would
smaller
increase MACE rate if you
Yeah.
injure the vessels.
balloon. Looks good, Ronald. Looks good.
Yeah, I
Iris.
think looks
I
beautiful.
Getting
the
in the
wall,
area.
the stand position is very good, and
For
the expansion is also good.
about 11.
You know, as long as you select strategy which is one that you are frequently using, if you know how to do it properly, I think you can achieve with different techniques really optimal result by IVUS.
Okay, Ronald, we'll, we're going to end now, but give us your final words on this case and your summary of the case.
All right, so we are going to take a final picture. We are moving the both wire out, and we are going to see the final picture very soon. Okay, Cindy?
Beautiful.
So in
Looks
summary,
very
this patient have a left main, also circumflex, and very diffuse LAD disease. We adopt a cool-up setting strategy with 3.5 stent to both the LAD and the and circumflex. And we final kissing balloon with 3535 balloon and final port of 4 mm times 8 mm balloon angioplasty. And the IVUS St. Andrew result looks pretty all right with the stand area of around 11 millimeter square.
Yeah. I mean, Ronald, it's more than
Yeah.
just all right. It's an excellent result. And I think all of us
you.
will agree. And we'd like to thank you and Gavin for the work which is done very well. Okay.
Thank you, Rosalie. Okay, see you in Suntec City soon.